Good morning. Before the real exciting talk starts, let me just talk just a couple minutes about a study about a phase 3 study that we're doing in treatment of pericarditis. We were involved in a phase 2 study using this agent called Recanalization, which is a subcutaneous injection. It's a receptor decoy of interleukin-1 alpha and beta. And the phase 2 study has shown promising results. We certainly know it's safe. With the phase 3 study, it is a multinational study including Australia and Italy. Interleukin-1 is an inflammatory cytokine. We know it's involved in many conditions, but specifically in pericarditis as well. And Recanalization blocks that marker or blocks the cytokine. Again, this has been a relatively large study. So far, 9 patients have been recruited. We got a first one, and we have 4 so far, so we're the largest site. Other sites include Cleveland, Mayo, and many others as well. So again, this is in patient who has pericarditis. So if you have any of these patients, please let us know. We'll be happy to look at it. Thank you.
All right, good morning. So it's about 2 months after the original date that was planned for this, but the snowstorm happened and almost happened this time as well. But thanks again for coming. This is an update on chronic total occlusion intervention. These are my disclosures. And for go back to it. Well, it's supposed to be 5 seconds, but I figure you're going to call Scarlett Cutler time on time. This is a little update on the CTO intervention where we are. And as you see, there's been lots of things happening, lots of things that will happen going here at MHIF and MHI. And this is what CTOs are, essentially 100% occlusions for 3 months or more. And these are something very common. 1 in 3 people have it if you don't have previous bypass. If you have previous bypass, pretty much everyone is going to have a CTO. Doesn't mean that you have to do something to it, but it's something that's very, very common. And I'm going to show you 5 scenarios about how we approach patients like this as a first step. So here's the first case. This was a patient referred to us from another state. The patient had ejection fraction of 26%, diabetic, and was referred for doing the circumflex CTO. So it was a complex lesion. The gerame was coming off right at the proximal cap. There's significant disease. But when you look a little more, there's maybe some disease into the LAD. And there is also disease in the right coronary artery. And the question is what to do about this patient. And of course, he was sent to us for CTO, but then the LAD didn't look quite great. So we did an IFR, which is a functional assessment, which was in the ischemia range, and then an FFR of the LAD, which is a measure of ischemia, and sure enough, the patient had significant disease in the LAD. So here is a patient who has diabetes, has 3-vessel disease, the CIRC, the right was significant, the LAD is significant based on this, and he's a surgical candidate. So for this patient, he actually went to bypass. And this is to show that CTO PCI is a tool, but you can use it when you need it. It's like every kind of revascularization. You customize it to the patient. That doesn't mean that everyone who has a CTO needs to be, first of all, having anything done to them. And sometimes bypass works very well for those complex patients. And this is one algorithm that kind of describes our approach to this. First of all, if the patients don't have symptoms or other problems, we may not revascularize, but if they have symptoms, which is the main indication, the next question is, do they have previous bypass? Because you wouldn't do repeat bypass if you have bypass. But then if you don't have bypass, then if you have multivessel complex disease and the patient is a surgical candidate, then bypass remains the treatment of choice based on both American and European guidelines. But for other people, especially those with single vessel disease and those who have previous coronary bypass graft surgery, then PCI is a good option. Moving on to another case to show how and why we do this.
My name is John Morensai. Prior to the procedure, I could walk 50 yards at the very most, and then I had to stop and wait for like a minute or two to kind of catch myself back up again, and then I could go on. Eventually, toward the end, I could walk no more than a minute or two without having to stop. And now, since the procedure, I am able to walk on the treadmill 20 minutes very easily. Earlier in the week, I took two of my grandkids on a 55-minute walk in the stroller all around our association, and there was no distress whatsoever. So it's like night and day. I have not felt this good in over 10 years.
Again, we didn't coach the patient to say these things, but this is to show the main benefit for CTO PCI. I think the most established indication right now in 2019 is to improve the patient's symptoms. So when do you do CTO PCI? You do it when the potential benefits are more than the potential risk. And CTO PCI does have risk, as we'll discuss later on, and the risk is about 3%. And the major benefit is in terms of improving angina, exercise capacity, and quality of life. There are now 5 randomized control trials, which is a major change. In the last year, we've seen 4 of them being presented or published. The one done in Europe is the EuroCTO trial for 100 patients, randomized to medical therapy or CTO PCI. And these were people who had essentially single vessel CTO disease. And what was found is that at 1 year, the quality of life was significantly better in those who underwent PCI of the CTO versus medical therapy. There's another trial just published in CERC called Decision CTO that was done in Korea. That had a primary endpoint death or myocardial infarction, but multiple limitations. It included multi-vessel disease and CTO. There was 20% crossover from the medical therapy to the CTO PCI group immediately after randomization. The study was negative, didn't show any difference in death, myocardial infarction, and CTO intervention versus no CTO intervention. And then there are 2 randomized trials for ejection fraction as the primary endpoint. One's called the Explore, that was in patients with STEMI and a non-culprit CTO. No difference in ejection fraction at 4 months, but success was in the 70% range, and there was no viability in the territory of the myocardial infarction. And then a study from Germany, Ribas, once again negative, but the EF and baseline was 59%, so it didn't really include patients with cardiomyopathy. That was a smaller study, single center from Russia, showing improved quality of life and exercise capacity in patients undergoing CTO PCI. This is a study we had started actually in Dallas, and it finally moved here, and will be launching the international group hopefully in the next month or so. This is the first sham-controlled intervention for CTO. It's like the Orbita trial, for those of you familiar with Orbita, but done in the CTO group. Again, small study, 140 patients, but this is the one that we're very excited to do because we believe in the right patient. That's going to show the clinical impact of CTO intervention on symptoms, and also going to have a Fitbit in every patient to see if their exercise capacity really changes or not before and after the procedure. And this is from a document that is about to be published in CERC, which is a collaboration of 101 operators from 50 countries, showing that there is actually global convergence now and agreement in terms of why and how to CTO PCI. And the number one thing is that the principal indication based on the EuroCTO trial and multiple observational studies is to improve the patient's symptoms. Are there other potential benefits? Absolutely. This is from Bobby Ye from Beth Israel. He showed that people who are depressed are more likely to have symptoms, and many of the people who have CTOs get depressed. And that actually, if you have depression, you are more likely to have bigger benefit if you recanalize the vessel. This just came out in JACC intervention, showing that if you have a CTO in depression, you have worse symptoms, but you have similar improvement than those patients who do not have depression to start with. This is the concept of double jeopardy. These are patients who have a CTO. If they happen to get an acute coronary syndrome, whether it's STEMI or non-STEMI, their short-term, 30-day, and long-term mortality is 3 to 4 times higher than if you don't have a CTO. Now, that does not mean that you're going to get something, because most of the people don't, but if you have a CTO, your potential for getting worse outcomes with an ACS is there. Few people come like this with electrical instability, multiple ICG shocks, or multiple refractory arrhythmias, and in people like this, revascularization with CTO can help. Another concept is that if you have CTO and you have good collaterals, maybe the collaterals are good enough and they're going to take care of the ischemia. But if you do a study where you cross with the wire and before you put stents, you do an FFR, every single patient had an FFR less than 0.8. So as long as your myocardium is viable and you have a CTO, you are going to be ischemic regardless of how good your collaterals are or not. This is Santiago Garcia's classic meta-analysis on complete versus incomplete revascularization. Well shown that if you have incomplete revascularization, your subsequent outcomes are going to be worse. And the number one reason for incomplete revascularization in multiple studies, including SYNDAX and registries, is the presence of chronic total occlusion. Here's another case, patient coming with non-STEMI, diabetes, 3-vessel disease, but he was turned down for coronary bypass graft, ICD, and ischemic cardiomyopathy. And this is his angiogram. It's pretty much left main disease with previous stents into the LAD. And then he does have no significant disease, except for diffuse distal disease in the right coronary, and also has a surge CTO. So this is clearly a very high-risk patient, 3-vessel disease, ischemic cardiomyopathy coming in from STEMI. And if you look at EXPLORE, as discussed before, there was actually no difference in ejection fraction before and after, and the same for the REVAS trial. But in this particular patient, we were able to recanalize him, and then 3 months later, his ejection fraction improved to 45%, his New York Association +1. So yes, if you start with a normal EF, it's unlikely to see an improvement in ejection fraction, but in patients like this, who have viable myocardium and have a significant ischemia and a CTO, revascularization can help improve their ejection fraction. And this forms the impetus for this study, which we're still in the early stages of launching, called REVIVE CTO, which, similar to SIGN, we want to show that in people who might benefit, and these are the people who have low ejection fraction to start with, doing CTO PCI is going to improve ejection fraction as measured by cardiac MRI. Here's another case. This is a previous coronary bypass graft patient, and it turns out that in the United States, about 40% of the patients who have CTO PCI are having a previous coronary bypass. So this is a patient who comes in with an occluded vein graft. And what you know is that even if you recanalize the vein graft, chances for this staying open long term are not the greatest, especially if it's completely occluded to start with. This was a patient actually who had an undilatable distal lesion. So we tried for many balloons, many high pressure inflations, could not dilate that distal lesion. And we do know that whether you put drug-eluting or bare metal stents, your outcomes after stenting of vein grafts, again, is going to be poor. In contrast, if you can open the native coronary arteries, then your outcomes further down are going to be much better than if you recanalize the saphenous vein graft. And this was back, almost 10 years now. There's the first cases where the native is open instead of the saphenous vein graft. And this is an algorithm now, because many people, interventionalists, are saying we should not be treating the vein grafts. Instead, we should be opening the native coronary artery instead. And this is one algorithm how to do this, because the reality of it is some of the native coronary arteries can be very complex. CTOs, high-to-treat lesions. So if you have a complex vein graft lesion and you can treat the native is the way to go. But of course, for the simple vein graft lesions, we still treat the vein grafts in most of the occasions. And one of the advantages of having bypass is now you have more conduits you can use for the CTO procedure. So you may have bypass grafts, arterial or venous grafts. You can go retrograde using those bypass grafts. So this particular patient with the undilatable lesion, we brought here back 3 weeks later. We actually did a CTangiogram, and as I will show you, there's an ongoing collaboration with John Lesser, Joao Cavalcante, where we actually image those patients before, and that gives us a lot of extra information to plan the procedure and also to co-register during the procedure itself and be able to cross under having more guidance. So what we've seen here, this is the vein graft, this is the previous stent, this is the native coronary, and actually the lesion is a fairly focal distal lesion right at the the vein graft origin. So it's a very short occlusion. And sure enough, the wire went fairly easily all the way down to the previous stent, but then we did have a hard time going through the previous stent. It was very calcified, hard to penetrate despite various penetrating guide wires. So we ended up going what's called subintimal, going on the wall of the artery but around the previous stent. And then we were able to re-enter distal to the occlusion. And now we have the wide distal through lumen. We placed several stents. And conveniently, the vein graft was occluded after we placed those stents, which is a good thing because you don't want a competitive flow. And then we have a nice result in the flow. There's no question that this patient's long-term outcome is going to be much better with this native coronary artery being open than having this subvenous vein graft with the balloon and dilator. So this is the concept of staged vein graft with vascularization. Iosif and Yanis, our fellow, just published this, where you come with acute vein graft failure. In the acute setting, you don't want to waste time. You want to get blood flow to minimize the injury to the myocardium. So you do that in the first stage. The patient goes home, and then comes back a few weeks later or months, and then you recanalize the native coronary without the pressure of the acute presentation. You can take your time and get a nice result in the native coronary artery, which again will give you better long-term outcomes. Here's another scenario. Patient coming in, and that's actually one of the, I should say, emotionally charged experiences of last year. STEMI, inferior STEMI, came in last year. This was the initial report. You can see the STs are elevated. No significant disease on the left system. But he does have significant lesions in the proximal and mid-right coronary artery. There are some previous stents, disease in central stenosis in the stents placed many years ago. And then during attempts to cross this, we actually had acute occlusion of the right coronary. It was difficult to engage radial access. We got acute occlusion. We tried to get femoral to get back in. We couldn't get femoral. The access was lost. We held pressure. We got the other femoral, trying to get back into the vessel. And then we saw this, which is the so-called intended bladder sign. And anyone knows what this means? So there's clearly something here pushing the bladder. And that something is a retroperitoneal hematoma.
I've never seen that, Manos. Can you talk more about that phenomenon?
Neither can I. So this is one of the reasons we do radial, obviously, which is the risk for bleeding a retroperitoneal hematoma. So you have now a patient who has an acutely occluded vessel and a retroperitoneal hematoma. Obviously not the best scenario. And for this, the treatment is to be able to go down and put a cover stent. Here is the puncture site. You can see here the extravasation into the pelvis, right over there. But unfortunately, we put a balloon, but couldn't deliver a stent. Actually, Dr. Alden came, and we're trying, and nothing would work out. So we ended up having Dr. Alden open up the patient on the groin and trying to get hemostasis. Unfortunately, while he was doing that, two things happened. The IVC got lacerated, and this happened. So at this point, it doesn't look very good. Essentially, have VF, VFRS, multiple shocks. The patient gets back into rhythm for a while, and then gets back into VF. And then eventually he goes on a Lucas device, and that's when our collaboration with advanced heart failure comes in, and Dr. Ekman can attest to have a lot of great collaborations over the last year. But actually, Dr. Frimievich was on call that night, and she came down, and essentially, this was the first ECMO I've seen where the surgeon put the cannula in the IVC under direct visualization. He was not very happy about it, but he did it. And then the patient actually got stabilized after he got placed on ECMO. And then we were finally able to get back in, and then we went around those occlusion areas around the previous stent, and were able to get back in and recanalize the patient. And actually, he was into refractory VF before all this. Couldn't get him defibrillated. Multiple attempts, nothing would work. The moment we got the flow back in the right coronary, the patient actually was able to be defibrillated back into rhythm. I mean, it was not an easy post-procedural course, but eventually he's discharged 17 days later, and actually, as of a few months later, he was able to ride his motorbike again. So this is an example, I think, where, I mean, obviously bad things happen, but through a combination of the help of advanced heart failure, which was critical for this vascular surgery, and then using CTO techniques to get back and recanalize his artery, the patient finally made it. So CTO intervention can be used not only for the CTOs themselves, but these are techniques that can be used in multiple other complex interventions and be able to provide the results that otherwise might not have been possible. And this is another study like this where it shows cases of acute vessel occlusion where CTO techniques are used to actually get the vessel back open again. So how do we do this? How do we get these CTOs done? And the hybrid algorithm that Dr. Beck was critically developing this earlier on remains kind of the blueprint for the U.S., North America, and increasingly other parts of the world. The first part is to do a dual injection. It is very important so we can see the beginning and the end of the occlusion. And then take the time to look at this. The techs are in the room. We have now a chief technician group that we meet every month, and we discuss these cases. And it's impressive to see how different it is looking at the film after 30 minutes versus 5 minutes. There are many things that you see that you wouldn't see at 30 minutes, you don't see at 5 minutes. And you look at 4 things. Where does the occlusion start? How long is it? You have the good distal vessel. And then you have vessels you can go retrograde and open the artery from that route. And again, many things we look for. And the difference in the last year or so, which has been the exciting part of the collaboration with advanced imaging, is using CTangiogram. And this is an example where here you can have a fairly nice entry into the occlusion. It's a soft tissue, no calcium, distal vessel is okay. Versus here where you have calcium, it's a longer occlusion. So CTA can provide a lot of information ahead to help us plan the procedure. This is another example where you have this LAD CTO and it's unclear whether the CTO is here, or there. But then once you do the CT, now it becomes obvious that actually this is where the CTO starts, and then you can plan your procedure and be more accurate, have less risk during the procedure as well. This is another example of a patient who had a right coronary CTO. When you do the CT, now it's obvious that actually it's not a normal right coronary, it's coming from the left cusp. You can see it very nicely here. Here's the CTO. This is the left main. This is the right coronary coming next to the left main, then coursing around and has the occlusion. This is much easier to do, obviously, than otherwise. And that CTO was fairly straightforward and easy to recanalize. So CTA, again, is becoming increasingly used for planning CTO PCI. This is another example where the patient has a distal right coronary artery occlusion. And from CTA, you can see the occlusion segment. It's a soft tissue, which is a good sign. It's easier to cross soft and calcified tissue. There's a good quality distal vessel. And sure enough, we were able to get through and recanalize this occlusion. Looking at composition of the vessel, once again, the CTA is very useful. It can tell you the length of the occlusion. Obviously, the shorter it is, the easier it is to recanalize. It can tell you very accurately whether there is calcium or not. The more calcium, the harder it is to get through. And it can also tell you if the artery has grown in size, which is the initial problem in coronary lesions, or if it actually has shrunk, the so-called negative remodeling. And that happens because the vessel is not perfused for a long period of time. The vessel actually shrinks, which creates challenges with standing because the vessel used to be a 3.5/4 vessel, now it's a 2.0. But you know if you give it time, it's going to grow up and become a bigger vessel as it was before. And then we look at the distal vessel. Again, the bigger vessel, the better it is. And we look at the collaterals, which is essentially ways to get back from the donor vessel, go around, and then cross the CTO in the retrograde direction. There are multiple scores that actually have been developed. This is the original one called the Japan CTO score. What you want is a tapered entry, no calcium, no bending, short occlusion, and no previous failure. And the less of those high-risk features you have, the more likely you are to cross quickly and be successful. There is multiple scores. This is the progress CTO from the progress database we post here. And for people starting this, always want to start with the simpler lesions, the JCTO 0.1, and then go to the more complex later on as time goes by. And this is an example of the CTO. this has blunt entry. It's a right coronary artery that's occluded. There's no calcium, but there's tortuosity. And then it's a long occlusion all the way from the proximal to the distal. So this is a complex CTO. This is one that should be done at centers that have all the equipment, retrograde expertise to get the best results. Multiple studies have compared CTA and angiogram, and it turns out the CTA is obviously much more accurate in assessing the severity of the lesion. And then when you look at the outcomes, if you did it by angio-guided, you had much less prediction of success than if you did it based on the CTA. So the message here is CTA can really help us plan those procedures. We actually have a protocol funded by Siemens that looks at this CTA planning and for registration. There's another score based on CT, looks at similar things. You have multiple occlusions, blunt stump, calcium, bending, and the lesions you want are something like this, which is short, focal, and no calcium. And you don't want this with a lot of calcium, multiple levels of occlusion. These are more likely to be failed procedures. A new thing we've been doing for the last year and a half is the so-called CCTA fusion. We go to the cath lab and we fuse the CT image with the angio, and then you can look at the screen, which are the lines of the vessel, can help you direct your guide wire. You can see this RCA goes up and down. This is very hard to predict based on the angiogram alone, but by using CTA, you can use this much more accurately. Also tells you if there is calcium, where are your guide wires, can really help you navigate through the CTO space. And this is an example of calcium, helping you select the best location for getting back into the vessel through lumen. So once you've done all this planning, we've done the angiogram, done the CTA in many patients, then you select your strategies, and those are either undergrade or retrograde. And undergrade means we're going down the direction of the forward blood flow, and this is one way to do it. The other way is to go around, which is the subintimal space. So we intentionally go around the former intima of the artery, go around it, and then get back into the distal vessel, like the case we saw earlier on. Then the retrograde, you go from the donor vessel, go around, and then get back into the proximal lumen. If you have simple occlusions, wires, undergrade wires will work, no problem. But when you go to those more complex occlusions, you're going to reach your retrograde, undergrade dissection entry, and that's why you need more experienced centers. Is there a price for this? Sure, there is. There's actually more complications when you go retrograde, more perforations, more myocardial infarction. So we do retrograde when needed, but if we can get the artery open in the antegrade function, that's obviously what we prefer to do. And lastly, we do a lot of changes of strategy. This is an example where things are very fluid. If plan A doesn't work, we go directly to plan B. And that's also codified in this consensus statement, showing that there's a lot of fluidity in how we do these procedures, careful planning, visual strategies, and change the strategy if the original one doesn't work. This is called the Asia-Pacific algorithm, which was published a couple of years ago, and this is the EuroCTO published a month ago. And essentially, these are all the same thing. I mean, there are some minor differences, like US does more dissection reentry, Japan does more wire escalation, but end of the day, we all do the same thing right now. So this field has really been transformed from being a lot of competition and antagonism and a lot of fighting in the meetings. Now actually, sort of pretty much we do similar things with minor differences all over the world. Another concept that is very important, especially when you spend 2 hours to cross and now you're spending another hour to stand and the room gets a little antsy, well, the bottom line is once you do these procedures and take the time, you really want to make sure your stand is as good as possible. You don't want to have underexpanded stands because we often put a lot of stents in these patients. You want it to have as well expanded as possible so you can minimize your stenosis, which is around 10% or so in most studies. And how do you do this? IVUS is very important, intravascular ultrasound. And this was one of the larger studies showing that if you do intravascular guidance, ultrasound guidance, your chance of MACE adverse events is actually less than if you don't. So if it takes us a little extra, I think it's well worth it. It's an investment for the long-term patency of the procedure. These are some of the sites from Progress. As I mentioned, this is hosted here now. Upward Northwestern Heart Foundation has provided funding for this, which we're very grateful for. And the outcomes right now are pretty good. Success is about 86%, complications 2.3%. And this is all the major series in the world right now, coming from Europe, from Japan, from Progress, UK, some more US. If you look at success, 85 to 90% across the board. Complications, 0.5 to 7%. About 3% is the average in Progress CTO. So we have come a long way. It's not 100%, but 85 to 90%. So we tell the patients for these procedures, listen, we have an 85, 90% success chance, which means that 1 or 2 out of 10 will not work. We don't know if that's you, but that's what it is. As an example, this is from last week, a meeting was in Turin. 12 cases done in 2 days. These are not easy cases. Every case was successful, and there was no complications. A few years ago, this would not happen. You have a few cases fail, but right now, it's not always 100%, but success is fairly high at experienced hands around the world. But if you switch gears and look at overall PCIs in NCDR, success is actually 60%. So it's a big gap. And the same is in England, Wales. If you look at overall success, between 50s and it's been increasing in the mid-60s, but still there's a 20 to 30 point gap between what can be done in experienced centers and what is actually done if you look at overall population. So this is where we currently are at CTO PCI in the world. You have the experienced centers with 85% success. But then you have the less experienced centers that have much lower success. And the key to move from here to here is education and access to equipment. But then the next frontier here is how do we go from this 85 success to 100% with 0% complication rates. And that's something obviously we'll have to work on. There are many exciting things in the horizons I'll show you in a second here. So in terms of training, this is something that's been going on for years and continues to happen. We start with the simpler techniques and then build it up with the more complex techniques. There is a book about how to develop expertise, and turns out that the best way to do that is the so-called deliberate practice, which means you have a specific goal, which is true for CTO PCI. You have a challenge, which is no question there's challenge in CTO PCI. And then when you practice, you are very focused in what you do. And you're able to monitor progress, which is very feasible with success rate and complication rates now in CTO PCI. And you keep the motivation going. But in addition to that, you have a good teacher. This is what makes the practice deliberate. You have all these components to maintain, but also a good teacher. That helps you get to the best success. And the goal of this is to create those mental representations. So if someone is sitting with a scenario, for example, this problem where the wire goes, but the balloon does not go, you should have in your mind an algorithm that I'm going to do A, if it doesn't work, I'm going to do plan B. And developing those algorithms for every possible scenario is what makes any operator, especially CTO operator, better, because then you know how to approach it, and then you do it faster, more efficient, and keep on learning doing this. So obviously there are many resources for doing that these days. Here at MHIF, there's many things we've launched. This is the PCI manual of CTO interventions, 170 cases already presented, 377K views. So it's been well received and a lot of education for us and for around the world. But education alone is not enough because what you want is practice. This is from NCDR. The more you do, the more your success, the less your complication rate. So just learning about it without having a good volume doesn't mean it. The second component for improving success is through technology. There's many things we use during the procedure. There are many microcatheters, several new ones that have come the last year, several new wires that come through, which I'm not going to go through right now. And there's also things like the CTA for registration, who have the e-card, I'll show you in a second, new systems for doing calcium, the plasma wire, high voltage electricity between two electrodes. Sounds scary, but probably is. This is an example where we do the same thing that structural does for transcaval. This is an example of a right coronary ostial CTO that we used, that actually Bill Nicholson used the retrograde approach, and they could not penetrate back. It was so calcified that nothing would go through. So what he did is he took the bobby, he plugged it to the back end of the wire, essentially burned his way through into the aorta. Now, obviously, you want to make sure you know where you are going when you do that. because the wire is going to go. You want to make sure it goes where you think it is. But again, another technique that can help you be successful. Another common problem for these CTOs and increasingly in our practice is coronary calcium. There are many tools. There is rotational or orbital atherectomy. We're actually part of the Eclipse trial, the first large randomized trial with a clinical endpoint. And there's a new device coming, which we're also going to be part of, which is the coronary lithoplasty. This is like the lithotripsy, which is you put a balloon, and then that emits those high-frequency waves, and those create cracks on the wall of the coronary artery, and then it makes it much easier with low pressure to inflate and actually dilate that vessel. The device is approved for peripheral use in the United States, and actually we're part of the Disrupt CAD, the coronary pivotal trial that's going to be starting very shortly over here. There's more developments also in terms of radiation. One of the concerns earlier on was, are we going to burn the patient's back? Are we going to get radiation skin ulcers? And actually with the newer machines, it has improved quite dramatically. But there's more things on the horizon. This is the control rad system, which you wear a pair of glasses, and it gives you high definition in the part of the screen that you're looking at, cutting radiation by 75% on the rest of the image, because you don't need full resolution of the corners. And the same thing can be done with a rad pad. And this is the mechanism. This is a special diaphragm that gives full radiation all in the small portion, and then cuts back on the radiation of the other portion. So you still have excellent quality in a specific part of the image, but less so in the other part of the image. So we've learned a lot of lessons for CTO PCI, and it's been quite a big growth over time. But that doesn't mean that we're there yet. There are many still unanswered questions about the patients. Does it have any impact on mortality? What is the success in the specific anatomic substrate and the specific operator? The complication, the risk of death. What strategy is going to be the most successful? How the technique can be better and get higher success, low complication rates? What is the cost effectiveness of CTO PCI? Steve Bradley actually has looked at this here, and fortunately it's profitable, so he lets us do it. But it's almost a concern because we do use a lot of equipment in this case. It's a long, the cath lab, it takes quite some time. And we're fortunate we have multiple labs running, but the more efficient we can do it, the less cost, obviously, the better it's going to be. So getting it from good to great has many, many other components. So to summarize, CTO intervention is a tool. Like bypasses, like regular intervention, like medical therapy, this is a tool. And can be used properly or not, and in the selected patients, that can give you really good results. Success is good at experience centers, but if you look at general population, there's still a lot of room for improvement. The main reason for doing it right now is for symptom improvement. Always assess the risk-benefit ratio. As I mentioned, there is now global consensus on how the techniques should be happening and the indications and the optimization of the stents. But there's clearly need for better techniques, but also for more operators and experts for doing this procedure. So again, thank you very much for your attention.
Thank you, Dr. Brilakis. The ceiling mics are on. You can go ahead and ask your questions.
That's a great summary, Emmanouil. Thank you. One of the questions I've always wondered about is, so if you have a native vessel that's got a CTO for 6 months, and you open it up, presumably there's all this organized fibrous clot. I would imagine that the sort of native endothelium is then squished under all this fibrous clot or just gets totally denuded. Can you talk a little bit more about the sort of the anatomy of once you've done this?
Sure. So the clot in general, if the mechanism for creating a CTO, as you said, is that sometimes you get tighter lesion, and then slowly it thromboses. And that's why you don't necrose the vessel, because this happens very slowly over time, so there's time for collaterals to form and prevent the damage of the myocardium. But then once it occludes, the thrombus organizes. So by the time you come to see it, which typically is actually many months or even years, there's no, would it be? Sure, we don't know for sure, but typically we don't see like thrombi and embolization. It was like 2 or 3 cases where you open it, then you have a piece of clot travel down and cause embolization. I think once you go through it, you create, in many cases, because you go subintimal, you actually create a new lumen. And you're putting the stent, and the stent is against fibrous tissue or the media of the artery, the media wall. So, and then it takes over time, you get new endothelium to come and cover it. But immediately afterwards, you're right, I don't think we have endothelium there. Whatever it was, we disrupted, and we opened it up. Now there is the stent and the wall of the vessel. That's why DAPT obviously is important for 6 months to a year.
Manas? Great talk. The complications are the Achilles heel of CTOs. Can you just comment on where we've been to where we are now?
Absolutely. So first of all, CTO does have more complications than non-CTO. Non-CTO would say 1-2%. CTO, the average is 3%. The thing that you're most worried, of course, is death, because there is less than 1%, 0.5, 0.9%, there's a risk of death during the procedure. The other risk that is fairly significant is perforation, which you're advancing wires, and sometimes it's unclear where the wire is going. That's part of the technique and the art of CTO. So perforation, and then myocardial infarction and donor vessel injury. If you go retrograde, you want to go to the donor vessel so you don't injure the donor vessel. It's been, this is the dictum right now. Going to 85, 90% success, you're still within 2-3% complication rates. But if you had to go from 85 to 100, that's where the complication rate spikes up, because you do more risky things like complex epicardials or things that are a little more risky than otherwise. So, and that's part of the art and the understanding how to do it. But always tell the patient there's a small risk. We say 3% of the average we see in progress, that's the average we've seen here. And then most of the complications turn out okay. But there's always something the patient needs to be aware of this, and that's part of the risk-benefit discussion. I mean, the patient who has no symptoms is feeling great. No, we don't do CTO PCI because there's not much to be gained. The patient who has a class 3 or 4 angina and cannot do anything, then he's willing to accept that risk of 2-3% because he's going to gain much more of that.
Emmanouil, I want to congratulate you on the remarkable work that you've done in the publications that you've made. Just getting them up there was quite satisfying. Sort of a corollary to Peter's question. When you look at stent durability, does it differ in the arteries where you deliver the stent basically through into the media versus the true lumen? And then how do you suggest we follow these patients long term?
That's a great point. And the question of subintimal versus true lumen has been a big debate over many years. There's now 5 or 6 studies, actually 2 are from us. There is 2 types of dissection. There's the so-called extensive and the limited. The one we do now is the limited. The Stingray system will go back in and minimize the stent length. For those, the restenosis reocclusion is about the same as the undergrade required true lumen. But in the past, we used to push essentially a knuckle, create a dissection all the way from the beginning to the vessel to the very end. And when you do that, your reocclusion rates are more than 50%. So we don't do this anymore. This technique has been essentially abandoned because the more extensive injury you create, then first of all you have longer stents, and second you have less outflow because you essentially occlude several of the branches of that vessel. So as long as we don't do the extensive dissection strategies, so to speak, I mean there's still 10%, but there's 10% restenosis rate. Extensive we don't do except for desperate cases where nothing else works. So that's the one part. For the follow-up part, people used to do follow-up angiograms. We don't do follow-up angiograms except for very specific scenarios. For example, the one reason you could do follow-up is when the patient comes back, and or if the vessel distally looks bad, and then we stand the proximal and say, let's give you some time because we know it's going to grow. Then the patient continues to have symptoms, then we'll bring them back in a few months, 2-3 months, and then see if the distal vessel has grown. There's a couple of lesions that we can treat afterwards. And this is typically much simpler on the CTO than the original procedure. But in the ones who do well, which is the majority and have good symptom relief, we don't do any repeat cath or stress testing, follow them the exact same way as for regular PCI, which is with annual visits, and then we give DAPT at least for 1 year. I must say I'm kind of biased. There's some data that maybe longer term is better. So we typically favor giving longer term DAPT unless they have a high risk for it.
Manas, if I may, the other thing that's important to remember is that in that chronic total occlusion, there is no true lumen in that segment. It's all fibrous, calcified, thrombotic, some thrombus and whatnot. There is no healthy endothelium in the middle of that. So going through the middle of that is, well, preferable from my point of view just because of its simplicity rather than dissection reentry. The tissue and the inherent healing in that is really no better and no different. You put a stent in the subintima, extending through there, that will endothelialize probably at the same rate that a stent does going through the middle of all that fibrous tissue. It's not like we're avoiding a healthy place to be and being in an unhealthy place.
Manos, a number of years ago, there was an observation made about injecting collagenase in the proximal cap, bringing the patient back a few days, weeks later, and this CTO was fairly easy to cross. Where did that go? It's still...
It's interesting you asked that. So this is Brad Strauss. Brad Strauss is one of the cardiologists in Canada who pioneered this. And I've met him at CRT. And there's a couple of challenges with this technique. The first one is it's a two-stage procedure. So you do the diagnostic, and you put the catheter, inject the collagenase, and the patient goes to the floor and comes back a day later. So logistically, it's a little challenging because it's a two-stage procedure, and people are saying, well, if I can operate 90% success, then why do all this extra work? That's one concern. The second concern is the FDA had want to regulate it as a pharmaceutical, not as a device, which, the threshold for approving a pharmaceutical is multi-fold harder than for a regular device. Having said that, they are planning to bring it, it's up to the FDA right now to get the study approved. In my mind, there is a role there, especially for less experienced centers. So if you, for example, go to Retrograde, this one might actually soften the proximal plaque and then help you cross antegrade and get it successfully where you may not be able to. And that maybe justifies the extra visit to the cath lab and maybe enables more centers to do this well. So this is, again, not in the near future, but it's something that is being discussed right now, probably come back in the forefront.
This is an argument that several of us have had over the years with CTO PCI and Manos, and I've had an extremely small role, but Manos and other people in developing and putting forth these techniques. And it shows that if you work extremely hard at it, you can get very good. The problem is that the number of people who are willing to put forth that kind of effort, failing as frequently as you do when you're first learning how to do that, with an increased complication rate early on in your experience, is very, very difficult emotionally. And I believe what we still need is a transformational technology. This is really good. This is helpful for those people who are severely, severely symptomatic. But until stents made a quantum improvement in PCI, and drug-eluting stents made a quantum improvement beyond that. I still believe that we need a transformational technology for CTO such that the average operator, the person that's not crazed and willing to sit there for a couple of hours and learn how to do this, is able to do this effectively and safely.
You know what technology, let me know.
I do.